And finish this regulation of extracellular fluid by the kidney. Of course, the kidney regulates the volume. خلاص خلصنا. So the kidney regulates the volume of extracellular fluid compartment as well as the constituents in it, mainly of course osmolality, as well as the concentration of sodium chloride in this compartment, because we said, you know, the majority or the overwhelming majority really of the osmoles that exist in the extracellular fluid compartment really are sodium chloride and sodium bicarbonate, and both are regulated by the kidney. Now we are trying to put and integrate, we're trying to kind of look at this whole thing globally, see exactly what happens when we have a reduction in sodium and water intake or an increase in the intake. How does the kidney or other systems respond to that? And we were talking about the relationship between extracellular fluid and blood volume. Remember, because the extracellular fluid compartment is made up of, you know, two compartments practically, the plasma, which is located in the intravascular compartment, and then you have the interstitial fluid. And we said these, under normal circumstances, the plasma is 3 liters, well, interstitial fluid is 11 liters, and they're usually in balance in the sense that the amount of fluid in each one of these compartments is determined mainly by the Starling forces. And we said the relationship between extracellular fluid volume and blood volume looks like this. Under normal circumstances, you have blood volume of about 5 liters and an interstitial fluid volume, or a total extracellular fluid volume of about 14 or 15 liters. As you increase the extracellular fluid volume because of increased intake or any other cause, blood volume will start to increase, but it kind of plateaus at about 7. Because any fluid you add to the extracellular fluid compartment above a blood volume of 7 will practically end up in the interstitial fluid compartment. And this, of course, might cause edema if you have used all the safety factor that usually prevents edema from occurring. And we said the safety factor is about 17 millimeters of mercury. So what are the factors that determine the distribution of fluid in the extracellular fluid compartment? How much am I going to have in the interstitium? And how much am I going to have in the plasma? It's determined by the Starling forces. Any change in the capillary hydrostatic pressure will cause a shift from one compartment to another. If I have a decrease in colloid osmotic pressure, because remember, colloid osmotic pressure in the plasma tries to keep the fluid within the vascular system. If for any reason I have a problem with the permeability of the capillaries, and that can happen as a result of an infection or the release of vasodilators such as histamine. It can happen as a result of inflammation. So the KF of these capillaries that we talked about can change, and of course that can affect also the amount of fluid that will be transferred to the interstitium. If I have obstruction in the lymphatics, if you have that, then the fluid that gets into the interstitium by the normal operation of, some of it is simply filters into the interstitium. If there is no way to get it back to the vasculature, it's going to collect in the interstitium, and that happens, of course, if you have lymphatic vessels that are blocked for any reason or they're not functioning properly. Again, the relationship looks like this, and if you think about it, really, the fact that we accumulate any fluid above a blood volume of 7 in the interstitium is probably another protective mechanism. Because remember, if you have a blood volume of 7, that means you're going to be, the heart is going to be pumping all that blood, and of course that's a burden to the heart, and as you increase blood volume even more, that will be more of a burden to the heart. So you end up really pumping all this fluid into the, and of course when you have an increase in blood volume, what's going to happen to the capillary hydrostatic pressure? it will increase, so it will favor filtering of any extra fluid to the interstitium. Of course, that you might end up having edema, which is a lot, of course, pulmonary edema is quite dangerous, but edema in other tissues, it's probably a little bit more safe for a human being as compared to increasing the blood volume by a lot. That will, of course, cause the heart to work a lot harder. Okay, what else do we want to know? So we are covering all the systems that get involved in helping the kidney or allowing the kidney to control extracellular fluid volume, as well as the concentration of sodium and other electrolytes in the extracellular fluid volume. So if for any reason the blood volume is reduced, and of course that can happen as a result of hemorrhage, or somebody having trauma of any type, whereby you lose blood, a lot of blood, then what happens to the pressure in the large pulmonary blood vessels as well as other vessels in the thorax? Well, if you lose a lot of blood, the pressure will decrease, and this by itself will end up stimulating or activating the sympathetic nervous system. Now, the sympathetic nervous system, remember, that leads to an increase in resistance in almost all blood vessels, so that will constrict the renal arterioles, and these are blood vessels that respond to sympathetic stimulation by constriction. So what's going to happen to your GFR if you constrict afferent to probably efferent? It's going to go down, right? And glomerular capillary hydrostatic pressure will go down if you constrict the afferent arteriole. And if I remember, with sympathetic stimulation, you have similar effect on afferent and efferent. So therefore, the GFR will fall. Anytime you have a GFR falling, remember the glomerulotubular balance. If the GFR falls, we start absorbing a lot of the fluid that is filtered. Okay, so therefore, in this constriction as a result of sympathetic stimulation will reduce GFR, which makes it possible to almost reabsorb almost all the stuff that was filtered. Then you will have sympathetic stimulation by itself, and the release of norepinephrine by itself will cause an increase in sodium and water reabsorption. Not only that, but stimulation of the sympathetics directly causes the release of renin. Renin is released, we said, as a result of a reduction in sodium chloride and the macula densa. Well, if I reduce my GFR, am I going to have reduced sodium chloride and the macula densa?
Yes.
Yes, so renin will be released, but also a totally different mechanism. Stimulation of the sympathetics, even if you do not change sodium chloride and the macula densa, will stimulate the release of renin. So therefore, renin will be released, and it will lead to the formation of angiotensin II aldosterone. So all these mechanisms, as you can see, will allow me to absorb more sodium, more water. Some of them are hemodynamic mechanisms, like we said before, because there are changes in resistance as well as GFR, or an increase simply in reabsorption as a result of sympathetic stimulation. Well, not only that, but stimulation of the renin, angiotensin, aldosterone system will also increase sodium and water reabsorption by the kidney. Now, if this drop in blood volume as a result of hemorrhage or anything else leads to also to a drop in blood pressure, what's that going to do to the baroreceptors or chemoreceptors? They will be stimulated, right? And these are stretch receptors. If the pressure drops, they will be less stretched, right? So they will send a message. Again, we know the message, how is it sent? Through the vagus as well as the glossopharyngeal nerves all the way to the nucleus tractus solitarius, and it will result in further stimulation of the sympathetic nervous system. Okay, well, why don't you go ahead? This reduction in blood volume also leads to a reduction in blood pressure. That will stimulate the baroreceptors, the chemoreceptors, all that. So that will be even further stimulation for the sympathetics. And of course, all this will lead to an increase in reabsorption of salt and water. Do you have a question?
Baroreceptors, if it's being stimulated, the sympathetic will gonna decrease.
It will be.
No, that's, remember now, this is, it was in the cardiovascular. Baroreceptors, it depends upon how you're thinking about it. If I have an increase in blood pressure, they're going to be stretched. The message that they will send is to inhibit the sympathetic stimulation. Now the opposite happens. If you have less, طبعا we say stimulation, but if the blood pressure is lower, then they will inhibit the sympathetic. Often, if the blood pressure is lower, they will stimulate the sympathetics. Okay? If the pressure increases, they will stretch, they will inhibit the sympathetics. The opposite will happen if the pressure goes down. Okay, so the end result is really stimulation of the sympathetics. Remember now, all these mechanisms, they work up and down. It's not, you know what I mean? They function both ways. However, as with most mechanisms, the baroreceptors, remember we have baroreceptors in the carotid arch and in the aorta. They have different ranges for the stimulation. So some of these mechanisms are more effective within a particular range of pressures. However, they function at all pressures, but sometimes they're more effective. And with the baroreceptors, they are very effective around your normal pressure. Okay? While, for example, the central nervous system ischemic response, remember that becomes effective when blood pressure drops down to 20 millimeters of mercury. Okay, so there are different ranges for these mechanisms. But nevertheless, if you have a reduction in blood pressure, the baroreceptors will stimulate the sympathetics, while they will inhibit them if your blood pressure increases and they get stretched. Okay, so is that clear? Okay, so all these mechanisms, again, that allow me to retain as much fluid as I can in response to a reduction in blood volume or blood pressure will be stimulated. Now, remember, the renin-angiotensin system also plays a significant role in modulating this relationship, the very steep relationship that I have between arterial pressure and sodium intake and output. Remember, the relationship that we have under normal circumstances is practically, it's not sensitive. We are not really sensitive to sodium, because you can see here, if I increase my sodium intake to 10 times normal, my output is going to be 10 times normal. However, my blood pressure will not be decreased much, will not be increased much. Okay, and angiotensin plays a significant role in that. How does it do that? If I am consuming a lot of sodium, usually angiotensin levels are very low, and when they are very low, they practically shift this figure to the left. Yani what does that mean? That means I will be able to excrete the amount of salt that I'm taking. I will be able to excrete it, but at a lower pressure. And this is the characteristic of the angiotensin system that we use when we use it for, when we give it to antihypertensive patients. Because what angiotensin blockade will do, it will shift this renal function curve to the left. So therefore, these patients can excrete whatever sodium they are taking. They will be in sodium balance, but at a lower pressure. But look what happens when we increase, for example, salt intake, but we do not allow angiotensin 2 to be inhibited. How do we do that? We increase salt intake and we give the patient, well, the animal in this case, we give them angiotensin 2. And you can see if you're giving them high angiotensin 2, that will shift the renal function curve to the right. Now, even if they want to, so you can see not only it shifts it to the right, but it also goes down, so the slope becomes less. So now if a patient is taking 4 times the amount of salt that they should be taking, look, they will not be able to excrete that except at a blood pressure of about 130. Okay? So that shows you the importance of angiotensin II in increasing when my sodium intake is very low and getting inhibited when I have sodium intake that's very high. So it plays around with my renal function here. And again, if for some reason a patient or an animal is not able to reduce their angiotensin II in the presence of a diet that is high in sodium, what they will end up being practically salt sensitive. Because now this increase in salt intake that they're consuming, in order for them to excrete that same amount, and remember, we have to be in sodium balance. I will not be able to do that except at a higher blood pressure, well, at blood pressure that is in the hypertensive range as compared to normal blood pressure. However, when you block angiotensin II, again, the renal function curve shifts to the left, and that's what you want to do if you are dealing with a patient who's hypertensive. And remember, hypertension, whether we know the reason or we do not know the reason, what happens in these patients is that the renal function curve is shifted to the right. So therefore, we want to bring it back. And one of the ways to bring it back is inhibit the renal angiotensin system. Of course, in some patients who are hypertensive, you cannot give them ACE inhibitors, okay, or cannot block the angiotensin system, because if you do that in patients, for example, who have renal artery stenosis, then their blood pressure will drop. Often their GFR will drop. So that's it's not indicated for these patients. But ACE inhibitors or angiotensin II receptor blockers are very useful as antihypertensive drugs, and the reason for that, again, because they shift the renal function curve to the left. So now I can be in sodium balance at lower pressures. Also, we have aldosterone helps me retain fluid, even though, again, we said the number one reason or the number one function of aldosterone is really regulation of potassium, but we also know that aldosterone increases sodium reabsorption. And we saw how that happens. It happens in the principal cells. It stimulates sodium-potassium ATPase, which is located in the basolateral membranes of these cells, and it increases the probability of having the sodium channels that are located on the luminal membrane to be open. And remember, these sodium channels can be blocked by amiloride, so they're amiloride sensitive. When they're open, I will be reabsorbing a lot of sodium. Now, we have patients that might come to you and they have Conn's syndrome, which is primary hyperaldosteronism, and they might have a tumor in the zona glomerulosa that's releasing a lot of aldosterone. And of course, by the time they come to you, the tumor has been there for some time, right? So what are these patients going to have? They're going to have about 10 to 15% increase in their extracellular fluid volume, and they're going to be hypertensive. But do you think they're going to be in sodium balance? Why aren't they going to be in sodium balance? Can you live if you're not in sodium balance?
It will be sodium.
No, you cannot live, you will die. These patients will be in sodium balance, but their blood pressure will be higher than normal. Okay? Remember, Leno, when they first started, when this tumor showed up, the first probably 6 to 7 days, they started retaining fluid, right? And they have high levels of aldosterone. They retained a lot of sodium, a lot of, so their extracellular fluid volume became higher. What's going to happen to their blood pressure in this case?
Increase.
It will increase, and it will continue to increase until a point comes, depending upon how much extra aldosterone they're secreting, a point will come where the pressure natriuresis response will be stimulated, triggered. Is that going to increase sodium excretion? Yes, so now you have two factors. One is causing me to reabsorb sodium, which is high aldosterone levels, and one is causing me to excrete sodium, which is pressure natriuresis. So you will come to a point where the sodium intake or output is exactly equal. But now my blood pressure is high, and because that is needed for me to excrete this extra, in order for me to be in sodium balance. At this time, we call this aldosterone escape. You remember we talked about this when we took the cardiovascular blood. Aldosterone escape, meaning that the kidney has escaped the effects of aldosterone. Even though aldosterone is still high, it's still causing me more reabsorption of sodium, but the amount that I'm excreting as a result of the increase in blood pressure, because I trigger the pressure natriuresis response, is equal. So, so now I'm in total sodium balance. However, during the first 7 or 8 days before my blood pressure increased enough to counter aldosterone's ability to increase sodium reabsorption, I was not in balance. Then I was excreting less sodium than I was eating. And that's why my extracellular fluid volume went up by about 10 to 15%. And that's why my blood pressure was going up during this period. However, it gets to a point whereby the pressure natriuresis is causing enough sodium excretion, or the aldosterone is causing sodium reabsorption, but the two are equal and opposite. Now, let's say I have a tumor that is excreting an X amount of aldosterone. And let's say I find out when the kidney escaped, the blood pressure was 130. So this patient was hypertensive, their mean arterial pressure was 130. And at that point they escaped. This pressure is high enough to counter the
Aldosterone.
the amount of salt that is being reabsorbed by aldosterone is now encountered equal to the amount that I'm excreting as a result of the increase in blood pressure to 130. Now the pressure natriuresis mechanism phenomenon will be triggered. So that happened when I have an aldosterone in my plasma of X. How about if I have a bigger tumor and it was releasing 2 times X of aldosterone? Is the pressure where the kidney will escape the effects of aldosterone, is it going to be higher than 130 or lower than 130 or equal to 130?
Higher.
For sure it will be higher than 130. لأنه more aldosterone, more reabsorption of sodium. So therefore I need that pressure to go up even higher to encounter, so the pressure natriuresis and aldosterone will lead really to innate reabsorption of sodium. And both are now equal and opposite. So depending upon how big the tumor is, or how much is the increase in aldosterone in the plasma, that will determine the final level of hypertension. Again, remember, this happened in these patients at one point. It only takes 8 days, about 1 week, and for this steady state to be arrived at. So what are the chances that these patients are going to come and see you during the 7 days? It's almost, the chances are extremely low. And they will not know what's going on. It will take some, in fact, people with hypertension, they do not know they have hypertension. And the symptoms are quite varied, and they might, there's nothing will be, they will not have any type of pain that will indicate to them that they have high blood pressure. In most of these cases, the way you catch it is because they come for a physical or they have something else, and you measure their blood pressure, because we always do that when patients come to see you, and you find out they have high blood pressure, but they usually don't have an idea. And we don't have an idea for how long they have had the high blood pressure. Yes, sir?
All this will happen for the obese,
No, not obese. What obese? That has nothing to do with it.
but the same mechanism we're gonna have for the obesity, right?
No, obesity, not necessarily that if you have, if you're more than, if your weight is a little high, that doesn't mean you will have a lot of aldosterone. Yeah, what you're talking about is totally different. If you take 100 patients who have essential hypertension, we find out that probably about 70% will be overweight. But you cannot conclude from that overweight is really what caused the high blood pressure. It's practically a risk factor. If there is a difference between associations and cause and effect relationship. Okay? And if I increase your blood pressure and I see pressure natriuresis, this is the increase in pressure caused the natriuresis, right? So that's a clear relationship. But the fact that we find out there are a lot of people who are overweight and they never become hypertensive. If it's cause-effect relationship, it should happen with everybody. This is simply, we're talking here about a pathology where you have a tumor in the zona glomerulosa that's releasing a lot of aldosterone, or in experimental conditions where we give animals infusion of aldosterone, and that's how we increase their aldosterone levels. We find out the higher the dose, the higher is the pressure when I'm going to have the kidney, when the kidney escapes the effect of aldosterone, and this is what we call aldosterone escape. So remember, when these patients escape, خلاص, I'm not retaining anymore, I'm not retaining net fluid. Even though I was retaining some fluid as I was getting to that high blood pressure. But whenever I get to the blood pressure, it's established now, the amount of salt that these patients are taking is equal to the amount that is excreted. However, during this period of 1 week, they retained about 10 or 15% of extracellular fluid volume, and their blood pressure is probably 10 to 15% higher than normal. Of course, that totally depends on the amount of aldosterone that this tumor is releasing. The more aldosterone, the higher the blood pressure is going to be before the kidney escapes from the effects of aldosterone. Is that clear to everybody? Okay. So would that be, now I'll ask you a question. You're asking me questions. So would this be essential hypertension?
Yes.
Why is it? Do I know the cause?
Yes.
You know the cause, so it's not essential. Second, I know it's caused by aldosterone. If I did not know the cause, then I call it essential or primary hypertension. So this is this is a patient with the 5% that you know the cause of the hypertension. Okay. So what else do we need to know? We have ADH also. Remember ADH, its number one regulation is the osmolality, the sodium concentration in my plasma. We saw what happens when the ADH osmoreceptor thirst mechanism is blocked. Then you increase my sodium intake, my osmolality will increase. However, when the system is intact, I can eat as much salt as I want. Of course, you probably will drink water after that. The thirst mechanism is working, and your osmolality is not going to be changing much. However, if for any reason I have water deprivation, I'm not getting enough intake of water, that causes, if you have, of course, if that will cause the osmolality to go up a little bit if I'm not getting enough water. So therefore, that will stimulate the posterior pituitary to release a lot of ADH, and we know what ADH does. It can go to the late distal tubule, collecting blood, so increases the reabsorption of water. So again, we find out that if you block this, again, patients will be dehydrated and they will be losing a lot of fluid in the absence of ADH. So again, this is another hormone that helps me regulate the extracellular fluid volume, and it's helping me reabsorb a lot of water. Whenever I'm water deprived or my extracellular fluid compartment goes down, or if my blood pressure goes down. And if you want to count the thirst mechanism, again, that works well. And thirst is usually this mechanism is stimulated if my blood pressure goes down or my blood volume goes down. So, and of course, that can have a direct effect on this mechanism of thirst. ANP, this is arterial natriuretic peptide. I think I made a mistake. This was discovered in 1981, not 84. It's not a big issue, but by Debold, again in Ottawa. I think he was at the University of Ottawa. So this is arterial natriuretic peptide, and it kind of does the opposite in the sense that it's released when I'm volume expanded. Less of it is released when I'm volume contracted. So therefore, again, what does it do? It's released by the arterial myocytes. It circulates, it's a hormone. It acts on the kidney. First of all, it depresses renin-angiotensin system. And it produces a small change or a small increase in GFR. And of course, if you have a small increase in GFR, that probably will decrease sodium reabsorption. Not only that, but it can also itself directly reduce sodium reabsorption in the collecting glands. Again, ANF is helpful, but we find out also in animals where you can block ANF or ANP, arterial natriuretic peptide, they're not going to have a huge problem regulating their blood pressure or extracellular fluid volume. So again, some of these mechanisms might be helpful, but they are not critical in terms of controlling extracellular fluid volume and blood pressure. Okay, and this is, now let's put the whole thing all together. I mean, we mentioned all these different factors that get stimulated or inhibited whenever I have changes in sodium intake or, so if I have an increase in sodium intake, what's going to happen to the extracellular fluid volume? It's going to go down. These volume receptors that I have in the large, blood vessels in the thorax, what's going to happen to them? Stimulated or inhibited?
Stimulated.
They will cause inhibition of the sympathetic nervous system, right? And that by itself will decrease reabsorption. Stimulation of the sympathetic nervous system will increase reabsorption by the renal tubules. The opposite will happen if you have less sympathetics. What's going to happen to renal resistance? Remember, these are if you stimulate the sympathetics, they will cause vasoconstriction. So inhibiting them will cause what? So therefore, the peritubular hydrostatic pressure, if you have vasodilation, is that going to go up or down? It will go up, so that will increase practically pressure in the interstitial fluid. I will shift more fluid to the interstitium as a result of an increase in peritubular capillary hydrostatic pressure. And this by itself will reduce tubular reabsorption. So you have a direct effect of the sympathetics on reducing tubular reabsorption, and you have some indirect effects. Okay, so if I decrease the renal resistance, what's going to happen to the filtration fraction? If I decrease the resistance in the efferent arteriole, what's going to happen to the filtration fraction?
Increases.
It will decrease, and my GFR will decrease. If I vasodilate the efferent arteriole, remember, I'm inhibiting the sympathetics. If I inhibit the sympathetics, am I going to have vasodilation or a vasoconstriction? Vasodilation. If you have vasodilation in the efferent arteriole, what's that going to do to glomerular capillary hydrostatic pressure? GFR. Filtration fraction. Decrease. Filtration fraction will decrease, so therefore plasma colloid osmotic pressure will decrease. Okay. I'm not, now the concentration of proteins is less even. So therefore, this by itself also will lead to a reduction in sodium reabsorption. Okay, so yes, sir.
We mentioned efferent, but won't afferent as well be dilated?
Yes, it will, and the chances are, again, it depends upon, remember, this sympathetic stimulation or inhibition, they have equal effect on afferent to efferent, okay? Now, but remember, I'm dilating both of them. What happens to renal blood flow? For sure, it's going to increase. The GFR, even if it doesn't change, let's say the vasodilation was in such a way where the GFR did not change, stayed the same. What's the filtration fraction? Isn't it GFR over renal plasma flow? If I increase renal plasma flow even without changing GFR, what's going to happen to the filtration fraction? Decrease. So either way, but chances are probably the GFR will decrease a little bit because of this vasodilation of the efferent arterioles. Okay, so now what happens if I decrease the renal resistance? What happens to medullary blood flow? The renal blood flow will increase altogether. Medullary blood flow will increase. Is that going to flush out the high concentration of osmoles in the interstitium? Yes, so is that going to lead to more excretion of sodium and water. Yes, then I'm not able to concentrate urine very much if I flush that osmolarity from the interstitium. Not only that, an increase in extracellular fluid volume, what is it going to do to my blood pressure? Increase, right? What is that going to do to renin? Angiotensin 2, aldosterone, and all of these will also lead to reduction in tubular reabsorption. An increase in my extracellular fluid volume, what is it going to do to plasma colloid osmotic pressure? It will decrease, my concentration of proteins is not going to go up. That takes a lot of time for the liver to start making proteins and all that. So therefore, that will decrease peritubular plasma colloid osmotic pressure, also colloid osmotic pressure in the peritubular capillaries, and that will also lead to tubular decrease in tubular reabsorption. Now, if my arteria, an increase in extracellular fluid volume, what is it going to do to my intraarterial pressure in the right atrium? Increase. Is that going to cause the release of A and F or A and P? Yes, so it will circulate and it will result in a decrease in sodium reabsorption. So you can see that we are talking about 4 big systems, well now, that come into action, and there are probably more. This is not the whole picture, but almost all these mechanisms, some of them are intrinsic to the kidney, some of them, such as, for example, aldosterone, that's not a hormone that's coming from the kidney, but it's acting with the kidney. ADH, it's coming from the posterior pituitary, but its site of action are the renal tubules. However, almost all these mechanisms really are coming, their site of action is the kidney. طبعا it has pressure natriuresis and diuresis, or glomerulotubular balance, or tubulo-glomerular feedback. All these mechanisms are also helping in first controlling GFR to the best ability that you can under these circumstances of increased extracellular fluid compartment. But at the same time, you're increasing the excretion of sodium and water, and all happened because I increased my sodium intake. And if your kidney is working normally, trust me, within a short period of time, you will have exactly no problem. You will have normal sodium excretion equal to your intake or output. And that's we know now by now. So sodium water balance. You need to have that, and you will have all that at practically a normal blood pressure. Again, because the kidney regulates all this and does it very well. Okay, any questions about any of them? If not, let's take about 10 minutes or something like that, 15 minutes, 10 minutes break, we'll come back. Thank you.